Hello, good evening, sir.
Good evening, ma'am.
So, everyone is just joining. We'll start in a short time. So, just give me 2 seconds.
Absolutely. No problem.
Yes, sir. Priyanka, ma'am, we should wait for some time, and we'll start in a two. We'll start in 2 minutes, ma'am.
मारणार आहे मला हे लिहून देतो मी तुला बीपी होऊन मला तू मारणार
I request everyone to please mute yourself.
To whom I have to make host?
Yes, me, sir. Dr. Abhishek, sir. I'm
Hello?
coordinator. I'm coordinator for today's webinar.
Yes.
To whom I have to make host?
Abhishek Kokare, sir.
Hello, Dr. Abhishek.
Yes, ma'am.
Yes, we'll wait for 2 minutes and
Okay.
ask everyone to join in the group,
Yes.
and we
Yes,
will
yes.
start. Okay?
Yes, ma'am. Yes, ma'am.
Hello, everyone.
Hello, sir.
Hello, ma'am. How are you?
We're fine. And how about you?
Just finished the cases.
We're waiting for your new surgeries again.
Yes. There are few surgeries that we did recently. I'll post them.
And congratulations for your 3D.
Thank you so much, ma'am. Thank you. 3D आते बराबर बहुत धमाका हुआ है हमारे यहाँ पे.
Yeah? Okay.
Daily we are operating endometriosis.
Endometriosis, yes.
Today we operated a case of large myoma. Unfortunately, that case was done in Alexis.
Okay.
So 20 centimeter, huge.
Whoa, that's great. That's a typical cases you have actually, और एनाटॉमिकली अगर ये चीजों को हमको देखना मिले तो और अच्छी बात है सर. तो आई विल रिक्वेस्ट यू कि आप इनको ये सारी केसेस हमको आप फॉरवर्ड किया कीजिए. आपके जो भी लाइव स्ट्रीम्स होते हैं, रिकॉर्डेड वीडियोस होते हैं.
Yes,
So
absolutely, we'll do that.
we are waiting for that since long time. I know your schedule, you're quite busy.
Actually, with the freelancing, it becomes a little difficult.
Yeah. Dr. Abhishek, ask everyone to mute themselves.
Yes, ma'am.
Yeah. Hi, Abhishek.
Yes. Good evening, madam.
Good evening.
Yes. I request all the dignitaries and the delegates to join as soon as possible. And I request to unmute yourself. Mute yourself before joining.
तुम्हाला 100 दिले ना मग अशी का नाही
Arpita?
पण घेऊन गेले
Dr. Arpita?
Yes, ma'am.
We
Ma'am,
are starting
actually,
our today's webinar.
You are the host now, I think.
Dr. Abhishek is the host, ma'am.
Okay, then
Dr. Abhishek, yeah.
सरांना सांगा
If you can please make me a co-host and Dr. Archana a co-host, we'll mute others.
Yes, ma'am.
there are a lot of disturbances. You may not be able to hear Dr. Pawan, so make everyone mute.
सत्तावीस तारखेला बोलवलेलं ना
Dr.
I
Abhishek has
request
left,
Dr.
I
Pooja
guess, ma'am.
Patil, ma'am. Yeah. I request Dr. Pooja Patil, ma'am. Please mute yourself.
Hello.
Hello.
Yeah, shall I start?
Yes. Dr. Abhishek,
Okay.
mute everyone. Huh?
I'll just get the charger first.
Yes. Do you have a PPT or that?
I have a PPT, but the PPT is just for the namesake. So I am going to brief and tell you everything according to my style only. So it is going to be a PPT but no PPT kind of a thing.
Yes. Okay. Absolutely fine. आप तो एक पेन और पेज लेके चालू हो जाओ तो भी हम लोग सुने. We are eager to listen you.
Dr. Archana, you are the host now. If you can just, manage the, other things.
So
Yes. Very soon we are starting
yes,
today's webinar.
at the outset, I would like to thank everybody for including me in this the webinar session to give a lecture of very interesting topic, that is myomectomy. See, myomectomy is something that is a very common procedure that is being done in day-to-day practices. I think all of us who is operating gynec surgeries must have come across doing these surgeries, because myoma is something that is very common tumor in the women in the reproductive age group, and nowadays we all are practicing infertility, so we cannot escape this particular disorder.
Yeah.
So today my topic is myomectomy tips and tricks. These are basically going to be the tricks that I use for doing myomectomies in my regular practices. Okay. So to start with, I always like to take the lecture into the basics. So I want to know what is fibroid. Okay. So fibroid is a one point. It is going to be a proliferation of myometrial cells that is going to start from one point in the reproductive age group in uterus. Okay, this is a simple definition of the fibroid. It generally happens because of the genetic preponderance into the myometrial cells. Under the effect of the estrogen, these myometrial cells are going to get proliferated, and from one point it is going to grow in all directions. Because it is benign, it is going to grow and not invade. Okay, so that's why when it is growing, it is creating its own space, and it is going to create a capsule around it. So all the myomas are going to have a capsule. All the adenomyomas are not going to have a capsule. So that is the basic difference, has to be understood. So the fibroid is a benign tumor that is going to have a pseudo capsule, and also fibroids are considered to be less vascular. Nowadays, like till now, when I was in my post graduation, I already heard that whenever you have a fibroid, there is a higher chance of bleeding. But fibroids are the tumor which are less vascular. They are not supplied very well by the uterus. They are considered as foreign. Okay, so that's why whenever you have a fibroid, you see the liquefactive necrosis in the center of the fibroid. You understand? Because the blood vessels in the fibroids are coming from the periphery, and when it starts growing, it becomes large. The blood vessels cannot reach to the center, and fibroid undergoes liquefactive necrosis. This is another basic thing has to be understood. Now, pathophysiology, as I have already told you, it starts from one point, and that is from the myometrial cells. Then proliferation happens. Then there is pseudocapsule. One important thing about the fibroid we have to know, that symptomatology of the fibroid will depends upon the pathophysiology of the fibroid. Okay, your surgical outcome of the fibroids or surgical procedure of the fibroid, or that is myomectomy, depends upon the pathophysiology of the fibroid. Why I am saying this? Because see, as we all say that it starts proliferating from the myometrium. These are the spindle cells, and myometrium is there in the myometrial layer. We have a endometrium, we have a myometrium, and we have a serosa in the uterus.
Yes.
So all the fibroids are going to be generated at the myometrium. So if the fibroid is close to the endometrium, that is the layer that is closer to the endometrium, probably I will just start. I will start the whiteboard, and probably you will be able to know it better that way. I think it is not helping. It's not working. I'll go back to the presentation.
Yeah.
So again, coming back to the original. So what happens when the fibroid is at the very close to the endometrium? It forms. It is a submucosal fibroid. Okay. When the fibroid is in between the endometrium, in the myometrium. So when it is submucosal fibroid, the submucosal fibroid will have a myometrial cells only on outer side of the fibroid, and inner side of the fibroid is going to be endometrial layer. Your endometrium. Okay. When the fibroid is myometrial, that means it is originating from the center point or midpoint of the myometrium. That time the myoma grows, and on both the side of the your fibroid is going to be myometrium. That is intramural or intramyometrial fibroid. When fibroid is growing on the outer side, outer surface of the uterus, that is lined only by the serosa, then it is subserosal fibroid. That means at this point of time, the myometrium, entire spindle cells are going to be in the inside of the myoma, and myoma will be facing outside, that is outside the uterus, that is abdominal cavity. Why I am saying all these things is because when you have a myoma that is submucosal, you are going to have more menorrhagia, you are going to have more dysmenorrhea, you are going to have more metrorrhagia. So when you have a submucosal myoma, all the symptoms are going to be pronounced. When you have an intramural fibroid, you are going to have more dysmenorrhea than menorrhagia. You understand? And when you have a subserosal fibroid, you are going to have no symptoms at all. The only symptom that subserosal fibroid is going to cause is compression. Okay, so that's why the location of the fibroid will be known to you once you ask this question to the patient and you know the symptomatology of the patient. That's why I told you this pathophysiology is very important. Also, when you are doing myomectomy, if you go in the abdomen, you realize that the myoma is there in the subserosal layer. That means there is no myometrium that is going to push the myoma out. You just give a elliptical incision on the myoma, because nothing is going to help you from the uterine side. But if this myoma is in the myometrium is going to contract and going to push the myoma. So if you see a myoma that is intramural, will be easily pushed out while doing the myomectomy. Okay, the basic. This is the basic that you have to know while doing the myomectomy. Now, when to do the myomectomy? See, we all know, every patient, you do the sonography, there is a 40% chances that you will find a fibroid patient. So when do we need to do the myomectomy in this patient? The important aspect of doing the myomectomy is the symptoms. How severe are the symptoms of the patient? If the submucosal myoma is causing anemia to the patient, if her metrorrhagia is disturbing her, if her pain is very significant, that is causing her not to avoid her working hours or working days during the menses. So all these symptoms when you have a submucosal fibroid, or the patient is suffering from infertility and you are having a fibroid that is more than 4 centimeters. Of course, a myoma that is submucosal of any size in an infertile patient has to be taken out. But other patients, like you come across the patient with like 40, complete her family, and she's having menorrhagia, metrorrhagia, she's having severe dysmenorrhea, or the fibroid is more than 4 to 5 centimeters. I'm sorry. I think we need to mute everybody.
Abhishek, please mute everyone.
So the symptomatic fibroid, or the fibroid that is having infertility, and also the fibroid that is compressing, that is subserosal fibroid that is compressing either on the bladder, on the ureter, or on the ureter, or nephrosis or hydroureter, has to be taken care of. Okay.
Dr. Raghavendra, please
Patient
mute
has to be.
also. Dr. Raghavendra Rai, Please mute.
Yes. Hello.
Please mute yourself.
So the
Hello,
basics
ma'am.
of myomectomy.
प्लीज म्यूट कीजिए सर, आवाज आ रही है, डिस्टर्ब हो रहा है थोड़ा.
अच्छा.
हाँ, थैंक यू सर.
Okay.
Dr. Pawan, please continue.
Yes,
Yeah.
yes. So when we try to do the myomectomy, whether it is open, whether it is hysteroscopic or it is laparoscopic. So mostly today this topic I consider it is a tips and tricks. So I'm going to focus only on laparoscopic myomectomy. So for doing myomectomy, your basic aim is to remove the myoma and suture the myometrium or the uterine wall in such a way that it does not have any scar formation in the myometrium, so that future pregnancies can be safely conceived by the patient. Okay, so this is the basic. You give as less possible incision as possible, take out the myoma, cause as less bleeding as possible, cause no hematoma in the raw area, and approximate the area so that hematoma will not be formed, healing will be better, and the superficial layer, that is the serosa of the myoma, is closed in such a way that it does not cause any adhesions later on. So these are the basic things that you need to do while doing the myomectomy. Okay, now what are my tricks? What do I do in laparoscopic myomectomies? Is first of all, I'm going to run a video of a myomectomy, and I'm going to each on every step I'm going to stop and I'm going to show you why I have done this, how I have done this, and what other things are available, and why I'm using what I'm using today. Okay, so use of vasopressin injection for causing less bloodless pills and finding the planes. The use of spinal needle instead of VVIN or whatever needles are available for installation of the diluted vasopressin in the myometrium. Second, then adequate incision, identification of the planes, delivery of the myoma by traction and counter traction, and suturing. These are the few tricks that I routinely use for doing the myomectomy in any patient. Okay, so this is a very small video, and this is the only video. I am not going to go into the very big myomas where it will be very difficult for you guys to understand what generally is done. This is the best case because this is a 6 to 7 centimeter myoma that is sitting in the posterior wall of the uterus, where I can depict all the tricks that I use for doing the myomectomy. Okay. Now, as you can see, there are two myomas. One is an intramural myoma that is there in the fundoposterior area, and one is a subserosal myoma. I am using only two ports for doing this myomectomy. I have gone inside with a myoma screw, and now you realize something that is coming inside. This particular needle that you see is a spinal needle that is 18 gauge. Okay, any spinal needle is approximately say 15 centimeter in length, and if you pull the uterus up, it is very easily you can do the hydrodissection with the help of this spinal needle. Okay, why I am using this spinal needle? Because I am using a vasopressin, diluted vasopressin. Diluted vasopressin, I use 20 unit diluted vasopressin, 20 unit vasopressin in 400 ml of normal saline. That is approximately 0.05% of the vasopressin weight by volume. Okay, so what it does not cause any after effect like vasopressin related complication that can happen in the patient because of this dilution, and also larger amount of NS will give rise to something that is called as venolock situation, where this compression because of the normal saline is going to block the vessels. Okay, now why do I use the spinal needle? Because see, what is important is you cannot put this diluted vasopressin inside the vessel. If you put it, you are going to have complications, and that can range from minor complication to death of the patient. Okay, so to know whether you are in the correct plane or you are not in the vessel, you need to have something that is going to show you that even with the smallest amount of the blood, it will show you that you are in the vascular space. And to know that, we are using spinal needle, because the dead space of the spinal needle, this 18 gauge spinal needle, is 0.04 ml. It is very less. So if you put that needle inside the vessel, immediately you are going to come to know that you are in the vessel. You don't even need to aspirate. Okay, so then you can readjust the needle and then you can push. So, and it is very easy, readily available, and you don't need to spend much on this needle. You just have to use it and throw it. So next time when you are using it, it is absolutely fresh for you. Okay, so this is a spinal needle that I am using. You can notice suprapubically I have gone inside. Now I am aspirating. Once I have confirmed that aspirate is negative, I am going to inject the diluted vasopressin. Now one more thing that you need to know: how much deep you need to go inside the uterus. You need to go deep enough where you feel the resistance, because the fibroid is going to give you resistance. Only exception is when you have a soft myoma. In soft myoma, you are not going to have any resistance. So in soft myoma, you have to go with your tactile sensations and be as superficial as possible. Okay. So again, I'm going ahead. Now you can realize the injection of diluted vasopressin that is going inside, and you will see the blanching that is going to happen on the serosal surface of the uterus. This blanching will cause decrease in the hemorrhage. There is one more thing that people, I'm really sorry. There is one more thing that people routinely do for, like, what are things we can use for doing the achieving the less bleeding inside the while doing the myomectomy. And one of the thing is ligation of the uterine artery at origin. Obviously, I do believe that ligation of the uterine artery at origin can be done in the patient who are having myomas more than 10 to 12 centimeter in size, abnormally located, and when you see the vascularity is too much. So even in those cases, when you have a patient who wants fertility, I would suggest to go for reversible ligation of the uterine artery with the Vicryl. Okay, not completely charring the uterine artery, because uterine artery is obviously there. God has created it. It has a purpose to supply the uterus. And it is, if you trying to coagulate the uterine artery, obviously the blood supply of the uterus will be hampered, and the orientation of the blood that is coming inside the uterus is going to be hampered. So try and not to fidget with anything that you think is important for fertility of the patient. So vasopressin is one thing, and the reversible ligation of the uterine artery is another thing that I routinely practice for reducing the blood loss during myomectomy. Now, third thing that comes is the incision. So now I am a surgeon who use contralateral force. So I am going to use a vertical incision on all my myomas. Horizontal suture, it is going to reduce the blood loss, and also there are a number of things they are going to mention. But for me, what is more important is hemostasis and adequate closure of the your incision that will reduce scar formation. Okay, so that's why I routinely use this particular vertical incision, and incision has to be adequate. They say if your fibroid is 6 centimeter, give a 6 centimeter incision, so that entire diameter of the fibroid can be nicely achieved. And once you give the incision, deepen that incision till the level of the fibroid, till the time you don't see the fibroid. And once you do that, your fibroid will automatically will be popping out. You can see this small fibers around the fibroid. These are the pseudocapsules. Okay, as you all know, mostly I use only 2 ports for doing all my routine cases, unless it is endometriosis or a very big fibroid. You can notice here, this is the point where you are going to see the fibroid. Once the fibroid is out, you are going to have this fibroid was also, because the bigger fibroids are not just going to be the intramyometrial, they are going to reach up to the submucosal layer also. So at this point of time, when you are giving a traction and counter traction, you will realize that you reach to the area of the endometrium. Okay, I'm just trying to cut the pseudocapsule over it, and you will realize this fibroid is dumbbell shape. It is going deep inside the myometrium to reach up to the submucosal region. Okay, this is called climbing of the myoma. You dissect the myoma a little bit from the endometrium, from the myometrium and climb, that is, you advance the myoma. You can notice here is the place where your your endometrium is going to come in the picture, and there is a possibility when you can notice this floppy area here. You can notice that bubble that has come out. This pinkish tissue that is there is the endometrium. Okay, so whenever you reach the endometrium, you need to decrease the traction on the endometrium, and I'm really sorry again. Decrease the traction on the endometrium so that opening of the endometrium can be reduced. Here you can notice I am using the very smooth action on the endometrium. There is a small button that is created on the endometrium. Try not to exercise unnecessarily. If you exercise the endometrium, chances of assurance are there. But if you open the endometrium accidentally, it is absolutely fine. This is going to help you draining any hematoma that is caused in the bed of the myometrium. Okay, this is another subserosal, small subserosal fibroid. I'm not going to inject anything there. I'm just going to excise this fibroid with the help of bipolar shearer, as this fibroid is absolutely subserosal. Okay, so once it is done, so the one very important point I need to discuss here is opening of the endometrium. As I told you, the opening of the endometrium is not going to cause any problem to the patient. It is not going to lead to a lot of Asherman syndrome that was a dictum earlier, and you did not to close the endometrium. If you remove excess amount of the endometrium, then there is a problem. Then you might have the chances of intrauterine adhesion. But small button in the endometrium is not going to cause any problem. Okay, so be absolutely sure that having the endometrial injury is not a problem. Now, next thing comes is the suturing of the bed of the myoma, and that is I feel is the most important thing. And routinely I use this unidirectional barb suture that is from the brand True Barb, that is Suture India. It has a unidirectional barb, so that you don't need to put extra traction on the sutures, and also it gives equitable pressure on all over the myometrial bed, so chances of formation of the hematoma is very less. Okay, earlier I used to use Vicryl, but Vicryl gives a lot of trouble while doing suturing also. So this unidirectional barb is absolutely fantastic suture, and it will definitely reduce many complications that can happen because of suturing. Okay, now here while suturing, you just have two layers. Okay, you have in the uterus, we have three layers of the uterine wall. That is endometrium, myometrium, and serosal layer. Okay, so endometrium you are not going to suture, so the rest of the two layers only have to be sutured, and then the myoma has to be sutured only in two layers. There are people who are suturing it in 3 layers, 4 layers. There is no need. If you suture in that way, the uterine architecture can change. So the only 2 layers has to be closed, and third layer has to be if at all you have a very big dead space in the myometrium, then in that case you can take a few bites to cover that dead space, but don't suture the myometrium in 3 layers. Now this is the backhand suturing that I am doing on the posterior wall, because I told you I generally use the quadrilateral suture. This particular barb suture has a wedge kind of a thing that gets stuck. You don't need to put it through the eye or anything. You just need to pull it, and that wedge is going to get entangled. You can notice again the same thing has to be done. The myometrium only has to be closed. Okay, try not to leave any dead space inside the area of the myoma bed. because I have been called for few cases where somebody else has done a surgery. There was a huge dead space in the myometrium, and that has caused almost 8 to 10 centimeters, and she was in shock. So fortunately, we could save the uterus of the patient, but these things can happen if you don't close the myoma bed adequately. Okay. Now we are coming out. We are coming out on the serosa, and serosal layer has to be closed with the baseball sutures. Okay. The baseball sutures are like inside out sutures on both the incision.
Pawan sir,
Uh,
video
both
run
the
nahi ho raha, sir.
whatever edges of incision. Sorry.
Video, we are not able to
It's
see the
running on
video.
my screen.
Yeah, but it's not.
It is
we
running
can't
on my
see.
screen actually.
Okay.
I will stop and reshare it. Is it running now?
Not yet.
Priyanka?
Actually, sir,
No,
video is not synchronizing with your
No,
voice.
it is running
Yeah.
on my screen actually. Is it?
It's still not. Okay. Okay, now it is. Now it is.
Okay. I am just going to forward it. Have you seen the entire video or no?
No, sir.
Achha,
In between,
so I will do one thing.
Yeah.
I will just start it from the beginning. Now is it running?
Yes, it is. Again, stop. In between, it is stopped and.
Can you see the video?
We can see the pic, and fluently it's not running.
The video is not running.
Yes, now it is. Now it is.
So I don't know like how much have you seen in this video, but now I'm doing the hydrodissection at
Yes.
this particular point of time with the
Yes.
help of spinal needle. Okay.
Yeah. We can see that.
Can you see it?
Yes, we can see that.
Okay. Yes.
Are you
You
using
can see the
25
blanching.
needle, sir?
Sorry.
Which number of spinal needle you are using?
18 numbers. Spinal needle 18 numbers.
Okay. Does the lumen may
I
also?
think there is some problem in the network only.
Okay.
I cannot actually hear you, ma'am.
Oh,
Hello.
I can hear you, sir.
Yes. So spinal needle 18, spinal number needle 18 will not give you a lot of stress while pushing the saline inside the uterus, because you at least have to inject 100 to 150 ml of the saline. If
Yeah.
you use very thin bone needle, then there is chance that you might have a lot of pain in your wrist. Okay, so
Yeah,
that's why spinal needle number 18 is very good for doing the hydrodissection.
Okay.
So now this is the baseball suture that I was trying to show you. Can you see the video now?
Yes, we can. Yes.
Yes. So the baseball sutures are always inside out sutures. The way I'm taking, the importance of these baseball sutures are they provide good compression on the edges of the uterine incision, and also it provides good apposition. So the good compression will cause hemostasis, and good apposition is going to cause decrease in the adhesions post-operatively. Actually, we have done a lot of cases of myomectomy, and we have realized by using this technique of baseball sutures, when you open the case for cesarean section, you don't even realize which side of the fibroid that you have removed. Okay, so it works that nicely. So that's why these baseball sutures are very important for doing laparoscopic myomectomy. Actually, we use the same baseball sutures even in the cases of open myomectomy. Okay. Because the principle of, as I told you, principle of the myomectomy in all the surgeries are same, whether it is laparoscopic myomectomy or open myomectomy. Okay, even in the hysteroscopic myomectomy, your principle is going to be the same, because in hysteroscopic myomectomy you are going to have if your fibroid is FIGO level 2, then that means it is in the myometrium. So you just need to give a cut on the endometrium so that the fibroid comes out, and then you can resect it. Okay.
Okay.
So this is the end of the suturing, and you realize the bleeding is not there. Okay, hardly any bleeding was there during the myomectomy. And secondly, the apposition of the serosa is so nicely done. That probably she will not have any issues in the future. Now the myoma that is there has to be removed out. There are a lot of controversies on using the morcellator. This kind of mechanical morcellator. Nowadays people say that you have to deliver all the myomas in the endobag, but then I don't think how it works. According to me, the moment you incise the myoma capsule, your myometrial cells are going to be exposed. If you suppose the threat is accidentally injuring the sarcoma. So if suppose you are dealing with the sarcoma, you give an incision on the uterus, the cells of the sarcoma are going to spread. So just avoiding the morcellation is not going to help in that case. So having said that, I have never faced any patient of sarcoma that was undiagnosed and we have gone inside and did the morcellation for that patient. Morcellator is such a wonderful equipment that with the small incision you can actually take out the fibroid of 10-15 centimeter size, and the patient has don't have to undergo large laparotomy or mini laparotomy scars. So using the endobag or not using the endobag is not going to make any difference in that case, and that's why I use open morcellation. Whatever morcellation technique that I use the morcellator, and this is going to ease the myomectomy, and also will reduce a lot of pain of removing the fibroid from the abdomen, and this works fantastic. The only thing is that this has a working blade, so you have to keep it outside the reach of the bowel, because to the bowel you are going to land up in causing a big hole in the bowel wall. So morcellator can be used, but you have to be absolutely cautious about using it near the bowel. One more thing while doing the morcellator is you have to give head up to the patient, because when you give head load to the patient in routine laparoscopic procedures, obviously it is going to take the bowel up. But whenever you are having a large myoma, when you try to morcellate it, every time you release it from the morcellator, it is going to go back into the diaphragmatic area. So to prevent that and to keep this myoma in the pouch of Douglas, you have to give head up to the patient, so that with the gravity it is going to fall down and not towards the diaphragm. So it will reduce a lot of pain that is going to cause. And one more thing, while doing the morcellation, you just have to do the surface morcellation. Like try and keep the morcellator only on the surface, so that your strips that is going to come out are going to be larger and your myomectomy is going to be faster. Okay, so that's it. If you want, yeah, I can show you one of the video of hysteroscopic myomectomy also.
Yes, definitely.
Okay, just hold on.
Even we would like to share it in our group also. After session, you can send it to me. I will definitely going to share it in group.
Okay, okay, okay. Just hold on.
So here in the peripheral area, it is very difficult to get the V-lock or the barb suture that means what we can use in the metro cities. So we have to means compromise with the Vicryl. So
Yes.
I think yeah, and with okay, just baseball it is okay, but for the small fibroid we use means intermittent compressive
Yes,
suture.
that's what probably in the presentation I told you that the problem is when you have a smaller fibroid, definitely there is no point in using a V-lock.
Yeah.
In a 2 to 3 centimeter fibroid, 4 centimeter fibroid, you can directly use the Vicryl, there is no problem. But the problem arises when you have a larger fibroid.
Yeah.
The issue with the Vicryl is it cannot provide a continuous compression all over the myometrium. So the chances of formation of hematoma in the bed is very high. So you try to save 2,000 rupees for the patient, but if suppose patient lands up in hematoma, the cost that patient has to bear is too much. And also the ease of surgery that is there with the barb suture is tremendous.
Yeah.
Once I started using the barb suture, can you see the video now?
Yes, the pic we can see.
So this is the subendometrial fibroid that is there, and we are doing this procedure hysteroscopically. Okay, this is done with the hysteroscopic monopolar resectoscope under glycine distension. We are entering inside the uterus. This is the cervix. Okay, and once we enter the uterus, you are going to see a beautiful myoma. Yeah, this is the ostia, and that is the anterior myoma that we are stripping out. This is, as I told you, this is a monopolar resectoscope. Okay. And you can notice the myoma is sitting anteriorly. It is almost grade 1 to grade 2 myoma. That is the myoma, FIGO grade 1 to grade 2. Myoma is less than 50% of the myoma was in the endometrial cavity. We take out the strips. Okay. Till the time you see the pinkish color myometrium. Okay. You can notice this dirty yellow color is the fibroid that is there. This patient had come for the infertility and menorrhagia, and after doing this procedure, within 2 months she conceived. Okay, so this is the beauty of doing the myomectomy, because submucosal myoma is going to be a foreign body for the uterus. So the entire vascular architecture and the contraction of the myometrium is going to change, and it will not allow the embryo to implant inside the uterus. So just doing this myomectomy is going to give a lot of relief in infertility to the patient. Okay.
Okay.
So you can notice we are already at the level of the endometrial surface, and this myoma is going inside the myometrium. Okay.
Yeah.
It is deeper. But then if you go slowly, and one more thing that you can do, you can stop the pressure and you can again start. So by increasing and decreasing the fluid pressure, the myometrial contraction will increase. And as I told you, there is a myometrium behind this fibroid. That myometrium will contract and will push this myoma inside the cavity further. And also you can use the injection methergin. This injection methergin also helps in pushing the myoma. You can see a lot of strips in the end of the fibroid. And here you can notice almost all the myoma is taken out. You can see the pinkish color of the pseudo capsule that is there. Can you see the pinkish color now at the base of the myoma? That means the myoma is out. Only few strips of the myoma is left here.
Actually, the video is in the interrupted manner, so we are having
I
some.
think I will share this video on the group, because I don't know what is the problem, but
It's not running continuously, so we are.
there must be some problem with the internet. I don't know.
Yeah.
I will share this video on the group. There is no problem. Right now only.
Sir, do you think does it make any difference if we use the energy source, and if we are doing with the pole Caesar, that really make a difference during the implantation while treating with the infertility patients?
Can you see the video now? Can you? Is it visible on your screen?
Yes, yes, yes.
So this is ultrasound picture of the same patient post-operative. You can see the entire
Nice.
myoma is taken out. Okay, and nice endometrium that is there. Okay.
Yes.
So your question. Does it make any difference, right?
Yeah.
So the mode of energy, whether you are using scissors or bipolar resectoscope or monopolar resectoscope, it hardly makes any difference according to me. Because even if you are using a bipolar resectoscope, the amount of endometrium that is going to be scrubbed out is going to be the same. Okay. And it does not make any difference in doing myomectomy by monopolar or bipolar, because the way it proliferates in the bipolar resectoscopy, bipolar resectoscopy की लेनी चाहिए, मतलब जो भी whatever myometrium myoma you are removing with the bipolar resectoscope, same way with the monopolar resectoscope, after doing your procedure, the endometrium is going to proliferate. But in both the surgeries, we cannot rule out the chances of formation of adhesions in intrauterine. Okay, and the studies, there are multiple studies, nothing shows that it increases the chance of adhesions if you are using a monopolar resectoscope. In contrary, in rural places, because using the monopolar resectoscope is cheaper than using the bipolar resectoscope. If you are practicing in the rural area, the cost to the patient is going to be higher if you are operating with a bipolar resectoscope, because bipolar resectoscope element is working element is expensive. The unit, electrosurgical unit that you are using for using the bipolar resectoscope is expensive. So not improving the result but increasing the cost is going to be the scenario in that case.
Yeah. Okay. And what is your approach for multiple fibroids if we are having in infertility patients?
See, totally depends. If you have 3-4 fibroids, absolutely fine, you can remove it. But if you have a fibroid more than 7 to 8, or there are multiple fibroid uterus is studied, then what my advice is going to be, try to remove the bigger fibroid and try to remove the fibroids those are going to encroach on the endometrium. Okay, you can leave the subserosal or intramyometrial fibroid, because intramyometrial or subserosal fibroid are not going to affect as much to the patient. Okay. So multiple fibroid, larger fibroid has to be removed, but don't try and remove all the fibroids from the uterus, because if you try and remove all the fibroids from the uterus on the multiple fibroid patient, hardly any uterus is left behind. So even after the IVF, the chances of conception is less, and even if patient conceives, chances of rupture of the uterus is very high.
Okay. Dr.
Any other
Abhishek?
queries?
Yes, ma'am.
Yeah, now you can start the questions.
Yes. Anyone who having a doubts or a queries or questions, please put your chat box. Sir, we have one patient, 38 years, female, married since 15 years, primary infertility patient. Actually, I'm asking question you for because you are special interest in fertility during endoscopic surgery.
Yes.
Sir, patient presented sonography with multiple fibroids, with one of fibroid is in a corneal side. So how we approach for this case?
The biggest fibroid, multiple fibroids, and biggest fibroid is the corneal area.
Anterior wall 4 centimeter. And two of these are 3.5 and 2.5 something, and corneal is a 2.5 centimeter.
See, as I told you, if the fibroids are not very big, then there is no point in removing them, first of all. If it is coming in the endometrium or touching the endometrium, then only it makes sense to remove the fibroid. But you are particularly asking for the fibroid that is in the corneal area. Then in the corneal area fibroid, you have to be very careful not to injure the fallopian tubes. Because when not while removing the fibroid, but actually at the time of suturing of the fibroid, you might compromise on the fallopian tube opening or the ischemic area of the fallopian tube. So you have to be absolutely careful and try to identify if the fibroid is anterior, lateral, or posterior, and try and manage your incision accordingly.
Yes.
Sir, what special precaution we should take while doing the cervical fibroids?
Yes, very good question. The fibroid I was talking about in the morning, I did, it was almost 20 centimeter fibroid. See, whenever you have a intramyometrial fibroid, you are going to have a muscles around it. But when you have a cervical fibroid, it is all connective tissue. Okay, so you don't have any myometrium that is actually guiding the fibroid. So here you can compromise on the serosa. Because if you have a larger fibroid, opposition of the fibroid, those are removed, like the flaps of the fibroid, those are removed from the cervix are going to be very difficult. It is a very tricky thing because you are going to have very floppy margins. Okay, this flop. Well, you have to take multiple bites from the inner surface of the the flap and try and oppose it slowly. Okay, and one more very important thing while doing the cervical fibroid is to take care of the ureter very nicely. You have to dissect bilateral ureters and dissect it up to the tunnel so that they are under your vision and the chances of their injury, especially while suturing, is reduced. Okay. Yeah. So apart from that, doing the cervical fibroid, I would say is the easiest thing to do. Intramyometrial fibroid, you need to give a lot of traction. You need to do the suturing very meticulously. But cervical fibroids are very easy. They come out very easily. And the only thing you have to be very careful about is the ureter and suturing with the small bites. You cannot just suture just one puncture and come out. That cannot be done. If you are having this fibroid flap, you have to start your bite, one bite from here, another bite from here, third bite from here, fourth bite from here, and then you have to oppose it like this.
Okay.
Are you getting it? In normal myometrium, what you do, you go here, come out, and then tie it.
Yeah.
So that is going to be very easy. But with the cervical fibroid, this is the only thing you have to take care. You have to take multiple bites to close the entire dead space. Otherwise, dead space is left behind, and that might lead to hematoma later on.
Sir, can you share some of your videos of cervical fibroid so that we will?
Actually, there are videos of the cervical fibroid, but right now I have not opened it in the background.
No problem.
Definitely, I will post it on the YouTube because today's case was very difficult and it was a very liquefied fibroid. So definitely, I will ask for the recording and share it on YouTube.
Okay, one other problem that we face during the posterior wall fibroid is most of the times we found the patients in after that intestinal obstructions. I mean, post-op management. If we are
You're talking about bowel obstruction?
Bowel obstruction, yeah.
See, any intra-abdominal intervention is going to lead to some adhesion.
Yeah.
And the myometrium is very adhesion forming tissue as far as intra-abdominal any tissue is concerned. It's very adhesion forming. So if you leave any myometrium that is open or any myometrium exposed in the peritoneal cavity, something is going to go and get adherent there. So to prevent that, what you can do is you oppose the myometrium very nicely by baseball suture so that nothing is exposed in the abdominal wall. And secondly, what you can do, there are a lot of adhesion barriers available, but nothing works. Trust me. Adhesion form hone ka hai to hoga hi. So what instead you can do is you can take your omentum, ask the anesthetist to give little head up so that omentum can be mobilized in the pelvis, cover the entire suture area with the omentum.
Okay.
So at the most, what will happen? You will have adhesion of the omentum to the uterus, but bowel will be spared.
Acha. So
What
that we
happens
can.
when you have any bowel segment that is going and getting adherent? Mostly the obstruction is going to happen in the loose bowel. It is not going to happen on the rectum. It is going to happen on the ileum or your jejunum, because these are the loose folds of the bowel that is going to get adherent and then it will undergo twist.
Yeah.
You understand? And even if you have any bowel adhesions post-operatively that is causing obstruction, you just have to do simply try and give her a conservative line of management, because most of the time these adhesions, they solidify, they undergo retorsion, and the bowel will get adherent to some other portions also, whether it is going to stabilize these adhesions. So just put in the rice tube, put the patient in for NBM for longer period of time, and do the good RT aspirate. Mostly the subacute bowel obstructions are taken care in 3 to 4 days.
Yeah. Okay. Okay, Dr.
Another
Arpita?
question. Another question. सर पोस्ट हिस्टेक्टोमी में अभी इनफर्टिलिटी पेशेंट को कंसीव करने के लिए हम जो काउंसलिंग करते हैं, तो पोस्ट मायोमेक्टोमी हम उनको कब काउंसलिंग करना चाहिए कि अभी आगे ट्रीटमेंट कंटिन्यू करना है, कंसीव करना है, तो कितने महीने में वो हील, मतलब एनी डिफरेंस है लैप्रोस्कोपिक और एंडोस्कोपिक, मतलब हिस्टेक्टोमी हिस्टेरोस्कोपिक और लैप्रोस्कोपी में कोई डिफरेंस है क्या हीलिंग में? जो हम
No, it is absolutely same. I recommend all my patients to undergo fertility treatment, or if they want to continue spontaneous conception, I ask them to wait for 6 months. Till the time all the uterus is going to be healed nicely. See, the healing time is generally 3 months, but we extend it 3 more months. Okay. So after 6 months they can undergo their fertility treatment. There is no problem.
Okay.
And there is no difference whether it is open or laparoscopic fibroid excision. There is no difference in the opinion in their advice.
I mean to say hysteroscopic or laparoscopic, any difference?
Hysteroscopic.
Yes, hysteroscopic.
Hysteroscopic patient can undergo pregnancy right from say 6 weeks after the procedure.
Okay, thank you, sir. Anyone?
Sir, any precaution while doing the broad ligamental fibroids?
See, again, the broad ligament fibroid is again a very easy fibroid to remove. If I am given option of removing the posterior wall fibroid or anterior wall fibroid or cervical fibroid or broad ligament fibroid, my choice will be first will be broad ligament fibroid to remove, second will be cervical fibroid to remove, third will be anterior wall fibroid to remove, and last will be posterior wall fibroid to remove. Because posterior wall fibroid suturing is very difficult. Anterior wall fibroid is easier.
Do it very smoothly.
Cervical fibroid, as I told you,
very nice.
Yes. So the broad ligament fibroids are easiest to remove, because broad ligament fibroids are not attached to anywhere. You just have to give incision on the peritoneum. Broad ligament fibroid will pop out. You don't need to do anything. Only thing is that you have to take care of the ureter. That's it.
Okay.
Most of the broad ligament fibroids those are mentioned on sonographies are lateral wall fibroids. You just have to keep this thing in mind, because broad ligament fibroid is very, very rare. Very rare. Even if you have a small tag that is attached to the uterus, it is mostly a lateral wall fibroid that is you are going to find, because true broad ligament fibroid is going to be lateral to the ureter. Fibroid and uterus will have, you'll be separated by the ureter. So mostly these fibroids are very, very rare.
Okay. I have seen you most of the time. You start from the from the inferior side, and then you will come to the top of the suture line while taking the posterior wall fibroids.
Yes.
And you work with that your backhand strokes. So easy to go.
The sutures are backhand, yes.
We need to practice it a lot, because though it seems very easy, it's very difficult. I know it's very difficult to manage with the backhand strokes.
Yeah, obviously it comes with the practice, but then if you practice, it is very easy. It is as good as suturing any other thing.
Yeah. Okay. Anything more, Dr. Arpita?
I think there is no any more questions regarding this webinar. First of all, thank you very much, sir. Actually, with the flow, we start already session without welcome message and introduce today's guest. Briefly, I'm trying to
His name is
introduce.
sufficient, Dr. Abhishek.
Yes.
The name is sufficient for his introduction.
Yes.
Not like that, but I am the integral part of NIMA now.
Yes. Thank you, sir. Thank you so much.
Thank you. But I'm trying to introduce in a brief. Dr. Pawan Gulhani, sir, MBBS MS ICOG, consultant laparoscopic pelvic gyne-onco surgeon, director of Medigrace Hospital, Nagpur, director of Inaya IVF and Fertility Care, and visiting surgeon at various hospitals in Nagpur. Operated more than 12,000 vaginal hysterectomies, more than 500 laparoscopic hysterectomies, more than 100 laparoscopic radical hysterectomies, laparoscopically managed more than 1,500 patients with severe endometriosis. Special interest in fertility reserving endoscopies. Thank you so much, sir, for this wonderful session and very informative session. Now, I would like Dr. Arpita Shah, madam, to take a question and answer. I already question and answer is done, session done. On behalf of NIMA OBGY Society and NIMA OBGY Maharashtra Society, I would like to express my gratitude to our NIMA Central, Dr. Ashutosh Kulkarni, sir, Dr. US Pandey, sir, Dr. Shantila Sharma, sir, for their remarkable support. I extend my gratitude to our NIMA OBGY Central President Dr. Kamini Dhiman Madam, Secretary Dr. Priyanka Nakade Madam, Treasurer Dr. Vishnu Bhavane Sir, convey to the Rajesh Uttani Sir for the supporting and guiding to the conducting today's webinar. I would like to thank and extend my gratitude to our eminent speaker Dr. Pawan Gulhane Sir, who took time from their busy schedule and delivered very knowledgeable and wonderful session. I would further like to extend my gratitude to our NIMA OBGY Maharashtra President Dr. Suhas Sirlekar Sir, Secretary Dr. Manoj Gaikwad Sir, Treasurer Dr. Ajay Raj Bhai Sir for their support to conduct today's webinar. I would like to thank Dr. Girish Daga Sir, Dr. Arpita Shah Madam for the help and the technical support. Last but not the least, I would like to thank from the bottom of my heart to the delegates for their participation and presence. Without them, this webinar would not have been possible and succeed. Now, with due permission of all the dignitaries, I am concluding today's webinar. Thank you for attending and hope you all learned and gained knowledge from the today's speaker. Thank you.
We would like to see you, sir, again.
Yes, absolutely.
Yes. Thank you. Thank you so much.
Thank you so much. Bye-bye.
Bye-bye.
Thank you so much, sir.
Thank you, sir. Thank you, ma'am.
Yeah, bye.